Hey, everybody, welcome to another episode of Peer2Peer, the podcast. I'm excited to step in for my good friend from Australia, Ben LaHood, and guest host this episode. We're talking mostly about drop-free or drop-less post-cataract surgery. And two amazing guests with me who have also been part of a study that we're all part of, Cathy McCabe and Brian Shafer, who's going to help us out talking to you about kind of why we think using a dropless regimen postoperatively is a benefit, and talk about a study that we presented at AAO, talking about the benefits of it and really what did the data show us from a safety and efficacy standpoint of view. So with that said, I'm excited to introduce to you Cathy McCabe and Brian Shafer. What's up, guys?
Well, I'm super excited to be here with two of my favorite people talking about really exciting things that help us to deliver care in a way that doesn't require more from our patients, actually requires less. So very, very excited to show everybody or talk about what we've been working on.
Awesome. I couldn't agree more. I'm so excited to be with you two. It's always such a fun time when the three of us are together. And I agree, we're moving everything in the way of interventional ophthalmology, taking control out of the patient's hands and putting it in our own. And this is a great, great representation of that.
I love it. I love it. And with that said, so let's talk about that. So what we're talking about to you is how we can use OMIDRIA, intracameral ketorolac and phenylephrine, at the time of cataract surgery, along with some other FDA-approved tools to decrease the need, hopefully eliminate the need for topical drops postoperatively in the cataract world. So, Brian, why is it important? Like, why are we even doing this in the first place?
Just last night, I was giving a talk to a group of primary care doctors. And in that talk, I said, who here has patients with perfect compliance? And everyone chuckled, because it's true in all aspects of medicine, in all aspects of humanity, that humans in general just aren't very good at being compliant with their medication regimens, whether that's eye drops or oral medication or diet. And we know that in order to heal effectively from a surgical procedure, we need to squash any inflammation, we need to prevent any infection, and we need to ensure that the eye heals appropriately. If we don't have proper compliance from our patients, we run the risk of higher rates of rebound inflammation and not healing the way that we really want them to. And in this day and age where we're really trying to achieve the best possible outcomes for our patients at the time of cataract surgery, it's paramount that we ensure we reduce any inflammation, and of course, prevent any infection.
Yeah, I always think of myself as a patient. And so I know that post-operatively, if I were trying to use 3 or 4 different topical drops and keep it on a regimen and get it in every time, I would definitely fail. So I don't think it's that our patients, and just exactly like you said, Brian, humans in general, it's not like we have particularly bad patients or something. It's just that none of us want the responsibility or are able to fit in the responsibility of having to take care of our care that way. And so if we can do it in a way that's reliable, comfortable, actually has, at least equivalent outcomes, and gives us that peace of mind and takes away that part of it that's just a hassle for our patients, that's a fabulous thing. So super exciting.
I mean, you think about how anal retentive we are at all of our preoperative diagnostic tests that we do, right? And even like a toric lens, if we're like a degree off, we're freaking out. And yet when it comes to the post-op period, we're like, yeah, whatever. Take a drop. You missed the drop.
Bye. Good luck.
Yeah, good luck. Yes, you never got it in the first place. You're missing your drops every other minute. It's just amazing how we lose so much control. And it is a big part of the healing process. And not just the end result, which is how does the patient doing at 90 days? It's the journey of that patient. I think, and I'd love to hear you guys talk about that. Cathy, talk about that too. Just the impact that we have now with patient satisfaction and the journey of healing, not just the end result of 2020 or 20 happy. It's how do they get there? Talk about that in your practice.
Yeah. So, it's very important to us how the patients feel about their experience around anything we do, their office visit, their cataract surgery, their outcomes. And that's one of the things that I understood it would be easier for patients and that they would like it. But during the study, to hear over and over and over from patients how I really love this eye, it's super easy. It was always more comfortable. They're getting more consistent and long lasting anti-inflammatory that's always there. But they definitely felt like this is the good eye and the experience, and this was not. And it's super important for us to feel like we are doing what we can to maximize that experience. I'm just going to bring up one other story because I did my mom's cataract surgery not so long ago. And it's my mom. We have very specific regimens for how people should do things that they check off all the time. And I thought, super straightforward. Hey, mom, and it was not in this study, and we didn't do a dropless, which I wish I had. But even doing all the things I thought were so foolproof for somebody I think very capable, I was saying, how are you using this? And it turned out she had found a very creative way of interpreting our schedule that was completely wrong. I was like, why would you see it that way? It looks so clear to me. And so I think sometimes even when our patients think they're doing it right, and we think we're being clear in communicating somewhat complex instructions, we're not necessarily being so clear. And they're not necessarily, even in their mind when they're compliant, being compliant because they misinterpreted what we wanted them to do. So I think that's another part of it that's really important.
And I mean, I remember, so many years ago when I used to do a 4-3-2-1 tapering of steroids, let's say, and you'd have a patient come in that they have their checklist and they have one eye and they have a second eye and it'd be different, regimens. And it was just like, even I was like, I have no idea what, I mean, it's color coded. I mean, it is tough. And I think I want to ask you, Brian, too, you started your new practice, Shafer Vision Institute. Congratulations, by the way. You've been a year now, I think, right?
Yeah, one year in August.
And I mean, you probably realize how important efficiency and flow of the practice is, right? These post-op visits are really hard. And as you get busier and busier and busier, we're getting more patients through the door, and we don't have sometimes the infrastructure and staff to spend a lot of time, but we want to spend the quality time. Talk about how much better quality time we have with patients post-operatively when we're not worried about the drops. So what's the efficiency and the flow like without drops versus drops post-operatively?
It's dramatically different. In fact, this is what I was thinking about while Cathy was talking here, is the patient experience is absolutely so much better when you don't have to be focused on your eye drop regimens, but the staff experience is also dramatically improved. And I'll tell you, even during this study, when I would have a patient who had their study eye, which was the drop-free eye, the dropless eye, versus their control eye, post-operatively, after the control eye visit, that visit sometimes would come to a screeching halt because I would say, do you know what you're doing with your eye drops? And they would say, sorta. And they would pull out their eye drop sheet and they would be checking it off incorrectly. And I would have to go and grab Aylin, my director of research, to come back into the room and print out a new drop sheet for them and explain over and over and over again. And that pulls Aylin off the floor. It pulls her away from another patient.
So we did some studies and some other studies from Lisa Nijam and others showing that you can save 5 to 7 minutes per patient per visit post-operatively by not having to deal with the PAs, the verification. Did you take your medications? Do you need refills? Did you actually get the medications? Are you tolerating it? All those questions and time that we spend, our staff spends, we can shave all that off. And if you're doing, 20, 30 cataracts let's say in a day, the post-op day, that can translate to a significant amount of FTE savings as well. So from efficiency and flow and patient satisfaction, absolutely. So let's talk about now the study, and let's talk about this. How do we get to this dropless world? And, OMIDRIA, intracameral rather, phenylephrine and ketorolac, is something that we're utilizing as kind of the core base for what we're doing to combat inflammatory cascade. So Cathy, do me a favor, tell everybody in the audience, just remind everybody, so why do you use at least OMIDRIA, and what is it doing differently than, let's say, a topical NSAID?
Yeah, so we have a couple of data points that help us to make this decision that it's important for us to get the medication inside the eye. And typically what we've always done is use a topical drop. And by using that either several times a day or even preloading by having a patient start the drop several days prior to surgery, we try to achieve meaningful dose and meaningful concentration within the anterior chamber and, maybe even in the posterior chamber. And luckily, we can look at data now. So Eric Donenfeld looked at a study where he either preloaded with a topical drop 3 days prior to surgery or used OMIDRIA, and then looked to see what the concentration of the nonsteroidal was in the AC and in the vitreous. And it was 200 times higher in the interchamber by using OMIDRIA, and it was more than 500 times higher in the vitreous by using OMIDRIA intracameral as well. So if we want to put something and have it be efficacious, how do we get it there? Well, just put it there. If you're putting it there during surgery, it's there. So that's why we want to use it, I think, preferentially intracamerally. But why do we care about nonsteroidals anyway? There's sometimes debate about that. But we have good study data, again, to point to. We can look at the pre-med study that looked at the component contribution to inflammation from either steroid, nonsteroidal, or a combination of steroid and nonsteroidal to see was there an additive effect, what was most important. And the interesting thing about that study, it was all topical, but the interesting thing was that the steroid decreased inflammation, the nonsteroidal decreased inflammation, the combination was most efficacious, but if you had to choose one or the other, the nonsteroidal was actually the most important. So I think that when we look at all of that information together, it's pretty clear to me why we would make foundationally a dropless strategy surrounding putting an efficacious anti-inflammatory inside the eye at the time of surgery.
Yeah, and having that's great summary. Thanks, Cathy. And having having this irrigation constantly irrigating with, ketorolac in the eye and phenylephrine. Brian, talk about, I mean, what do you think is doing to the actual, so it's minimizing the actual in stimulus of inflammation, right? So you're never letting it get past a smolder, so to speak. Talk about that. And you did a great job at AAO talking about that as well.
Yeah, the inflammatory cascade is one that once it starts, it's hard to put it out. It's like a campfire, and once that campfire is going, you have to really put that fire all the way out and prevent it from flaring back up. You can imagine the embers simmering at the end of the night, and you may go to sleep and then they pop back up. The goal is to make sure that that fire really never starts. And by quelling the inflammatory cascade from the very beginning, by putting the nonsteroidal in the eye, preventing the prostaglandin release, you're really just preventing that fire from even growing. This is why I think we have extraordinarily quiet eyes on day one when we're in this study and with these regimens, because the inflammation doesn't have the time to even start. And I think that that's just as important as putting it out.
Absolutely. And having phenylephrine also as well, Cathy, you've done some. First of all, Cathy is the most amazing surgeon I've ever seen. I had a chance now to go to multiple countries and see her just rocket some of these really, really hard, small people, rock hard cataracts, and just beautifully done. But there are some tough cases that you have, and talk about how it stabilizes the pupil and it doesn't necessarily dilate more, but talk about the other benefits of OMIDRIA just in case other people don't have experience with it.
Yeah, and I think, one of those things, if you start using OMIDRIA, and I think we're all accomplished surgeons and we think, we have tough cases, we have small pupils, we can deal with it, no problem. We've really found lots of different tools that help us to manage that. And we don't realize how many not horrible pupils, but sort of mid-range pupils would be so much better too if we had better stability of the iris over the course of the surgery. So years ago now, because time flies, started, implementing and integrating the use of OMIDRIA during all of my cases, not just cases that I thought, is this, somebody who might have more inflammation, they have diabetes, maybe they have a history of intra-uveitis, where I think it's critically important to have more anti-inflammatory on board. But every patient, I could see that I had just more iris tone, more reliably dilated pupils throughout the course of the surgery, and less stress on me, better visualization, which always is better for the flow and efficiency of your surgery and safety. And I really appreciate that. So there were periods of time in that whole process of OMIDRIA where maybe I didn't have adequate access to have it for all my patients. And I would then be reminded, oh my goodness, I forget what it's like when I don't have better pupil and iris stability over the course of every single case. And
I think that in my practice, at least, I see a dramatic difference in the amount of cases that are predisposed towards some iris prolapse with the use of OMIDRIA versus not.
Yeah, I mean, I as a glaucoma specialist, we get those, hyperopic, pseudoexfoliation, shallow chamber eyes, and I can tell you dramatic difference in how many times I have to use some iris expansion device. So for me, it's just been a decrease in those has really helped the AAC and of course efficiency and flow as well. And last thing I'd say is pain management. I think there's been great data sets showing us with OMIDRIA on board, patients have less pain during and after surgery and less need for narcotics and, all those other things as well. So I think in general, there's a huge benefit to using OMIDRIA during surgery. But now let's jump to what we are here to talk about finally, which is our study that we all did together, talking about how we can use OMIDRIA plus a delivery of a steroid triamcinolone acetonide as well as intracameral moxifloxacin, and how we can decrease the need for topical drops. So Cathy, do me a favor, talk about the study design a little bit there and kind of what we did, and we'll go through some of the data real quick.
So we enrolled patients who had cataracts and that we were going to be operating on both eyes so that we could randomize the patient to receive either a typical regimen of topical anti-inflammatories, including a steroid and non-steroidal, and topical antibiotic, moxifloxacin, or to receive the dropless regimen, which was OMIDRIA, subconjunctival triamcinolone, which we'll talk a little bit more in detail about, or in addition, intracameral moxifloxacin. So dropless versus typical drop regimen. And we looked at our primary endpoint was inflammation at day 8, but we had several other endpoints as well, including retinal thickness, macular thickness, and CME, subclinical or clinical CME. And we also looked at inflammation at several days, not just at day 8, but day 30 and day 90. So we wanted to spread it out at least to day 90 so that we could see if there was anything that happened even that far away from the implementation of our anti-inflammatories with a dropless regimen, and whether or not, was there any concern that there would be rebound inflammation or possible increased risk of CME. So, and we looked at patient responses and kind of what their experience was. So it was terrific, really a great experience. And my patients who were in the study, I just had a patient come back. She was like, yeah, I just want to tell you again, because it's been a while now since the very first enrolled patients. And she developed some PCO and she was there for that. And she was like, I just want to remind you that my study eye has still always been my better eye.
I love it.
Yeah.
But that's the cool thing, right? It was pretty clear, the patients knew already, which I felt better with. And I know, Brian, you've had some great stories of some of the patients you've seen as well. But talk about, so Cathy, thank you for setting that up. And Brian, talk about what happened. What were the results of, the inflammation, retinal thickness, et cetera, for the study?
So the study was powered to be a non-inferiority study. So we were really able to assess if the study eye versus the control eye were fairly non-inferior to one another. And that is really what we found. At day 8, there was no statistically significant difference in the amount of inflammation in the anterior chamber between the study eye or control eye. And just like the inflammation, we saw no statistically significant difference in the amount of CME between the two arms. This was really important because basically it showed us that this eye drop regimen is at least as good as the traditional eye drop regimen at reducing inflammation and preventing CME. However, the other important metrics that we were looking at here were the patient experience metrics. What did the patient prefer? And how much did it cost the patient? Because we asked them that as well.
Yeah.
I can't think of a single patient, truthfully. This is anecdotal. This is not based on looking at the exact data, but I can tell you anecdotally, I cannot think of a single patient who said that they preferred the control eye over the study eye. I can't think of a single patient. And I can think of many patients who complained about the control eye needing to use the eye drops, mentioning that, doc, I'm sorry, I think I messed up some of those eye drops, because that's just what happens to humans. And it was striking to see how clean the eyes healed up without any post-operative eye drops that were self-administered, and how much the patients truly just preferred it.
Yeah, I mean, hyperemia, things like that I'd noticed was less. I mean, obviously surface issues from all the preservatives, from the drops, just fluctuating vision was something that we do see here a lot of with post-op cataracts, and just seemed like, at least from what I could tell, a lot less with the study arm as well. Cathy, talk about what we did. So we did OMIDRIA and then triamcinolone. Not everybody's very comfortable or has experience injecting triamcinolone. So talk about how we did it and what was a patient experience like.
So yeah, we would inject the subconjunctival triamcinolone and at the end of the case. So pretty much everything's all done. I have it pulled up by my scrub tech. You do want to be careful that you agitate it within the syringe, because triamcinolone can settle out. So we flick the syringe several times. So there are some details to know. And it doesn't go through a 30 gauge needle very easily because of that larger precipitate that it is. So we would use a 27 gauge needle. And I like to have the patient look up. I would elevate the conjunctiva inferiorly with a 0.12 forceps. And I do warn the patient that they may feel a little prick right there, and then inject slowly enough that it's comfortable enough for the patient, subconjunctivally, infratemporal if possible. And patients, they're prepared for a little prick. Sometimes they notice that and they might say something there. I think the thing that's surprising to me, and I didn't really think about it a whole lot until another physician that I was talking to about the study asked me, don't patients hate to have that injection at the end of the case? And I said, the truth is, I tell them it's going to be a little poke there. By the minute later, they're not talking about it. By the next day, they never mentioned it. Not once did a patient who was saying their experience between the two eyes mention, boy, I love the fact that I don't have to use drops, but I really hated that poke. Not one of them even remembered it to say anything about it. So I think we think that patients might be bothered by that in some significant way, but at least in my patient population, my experience, it was a non-issue. They didn't really notice it much at the time, and they certainly didn't remember it as a negative compared to the arm of the study.
Yeah, I agree. And I think, when we talk about expectations, and how it's just letting them know, okay, here you go, 3, 2, 1, boop, and you're done. And I think once you manage that expation, patients are totally fine. So for me, it's like,
oh, this is minor.
This is minor. I think there's still a lot of docs who just aren't sure how to get involved with droplets. Okay, well, are there baby steps? Brian, talk about if there's surgeons who are not sure how to get involved with a dropless regimen, how do they get involved? Some pearls that you can share.
The most important thing to remember is that internationally, we have come to an understanding that intracameral antibiotics is important at the time of cataract surgery to reduce the incidence of endophthalmitis. That is the first step of ensuring that you can even march your way towards a dropless regimen. I know there are still many surgeons who haven't started to do that, and often it's logistic based, whether you're working at a hospital that needs to compound it themselves and whatnot. That's the first barrier that I would try and overcome. Get some antibiotics inside of the eye at the time of surgery. The next barrier to entry is just making sure that you have the ability to access OMIDRIA. The Rayner team does an amazing job of working with you as the surgeon as well as with your facility, whether that's an ASC hospital, HOPD, to ensure that you have access to the medication. This is a great med that a lot of us are using on every single one of our cases. I'm like you, Cathy. I use it on every case, and it makes a big difference. That's a really important step in making sure you can march your way towards dropless. And then the final piece is figure out what you're going to do with the steroid. There are different options for what you can do with that steroid to sort of mimic your drop taper. What we did in this study was subconjunctival triamcinolone, which is a very cheap and easy thing to do. There are also intracanalicular implants. There are other options for this as well, but starting with the antibiotic, moving towards the NSAID, and completing it with the steroid is a great roadmap to get yourself drop free.
Yeah, and Cathy, the fear factor of, okay, what happens? What's the worst that happens? Let's say at a week out, they have inflammation with the dropless regimen. What's the worst that happens? What do you do?
Well, you would put them back on an anti-inflammatory topically. It's not the worst thing in the world. So I guess that is theoretically the worst, terrible, horrifying outcome. But the reality is we had no patients in our study in any of our sites that needed some sort of rescue therapy with a topical anti-inflammatory. So I think that speaks to how efficacious it is. And boy, the drop, once you put a subconjunctival medication and you put the OMIDRIA in there already, it's there. We don't have to worry, did it go somewhere? Did it not get put in? We know it's there. So I think the chance of it failing is actually less than being reliant on compliance of the patient.
And I'm glad you brought that up. None of us had any rescue therapy needed. But look, worst case scenario, if you are, let's say you have someone in real life, you're doing drops, right? Not dropless, you're doing drops. And at 1 week out, let's say you had a complex cataract and they're a little bit more inflamed. What do? You increase their steroid, frequency. Same thing. You can start with steroid if you had to, but we didn't need to. And in fact, we didn't cherry pick patients, right, Cathy? I mean, we had
we
2 plus, 3 plus, 4 plus.
Yeah, we included patients who maybe had increased risk of inflammation. We included diabetics in our study. Some studies in the past, they were more cautious and try to make sure that there's no patient who might potentially have a higher risk of inflammation. But we didn't even do that. So in our study, it's pretty real world where we were including patients who maybe they would have a risk of more inflammation. And we really didn't see that in our study group.
So, this is preliminary data that we presented at AAO. We had 1 month data, but not the full cohort of patients had gone through their third 90 days yet. So we're going to be presenting the full cohort, the full 90-day outcomes of all of our patients at ASCRS 2025. So stay tuned to that as well. But to end it, both of you guys, love to hear your thoughts.
Remember to be nice to your staff and do whatever you can to minimize their burden.
And I'm going to say we look for the easy buttons for everybody. Easy button for your patient, easy button for the surgeon, easy button for your staff. It's a triple win.
Oh man, this is awesome. And I had the easy button having these two as co-hosts with me. This is awesome. So thank you to Brian. Thank you to Cathy. Thank you everybody out there. Thank you to Rainer for letting us be part of this Peer2Peer, the podcast. I hope you guys enjoyed it. Hope it was informative, and reach out if you have any questions. But thanks again, and stay tuned for another episode in the future. Take care, everybody. Thanks so much.
Thanks,
Thank
guys.
you.